My name is Megan Howe. I'm Chief of Staff with the National Association of State Mental Health Program Directors, and I am delighted to host this 988 Crisis Jam today. And let's go to the next slide. Great, and just want to note how you can access this learning community. The Crisis Talk website has the Zoom link. It has what the upcoming presentation is. It has past presentations and videos and materials. And some of those last week, for example, anyone can get broken. And it has the Crisis Jam trivia and the past quotes. It has Moving America's Soul on Suicide, which are amazing, an amazing series on the lived experience. And next slide. Great, and the top 5 crisis jams. This is super exciting to me because not only do you get to join this crisis jam live, but you can look back at the recordings. And so the top 1 was the youth edition. And on top of it, there have been so many YouTube access. Many people have accessed it by YouTube. That's exciting. So the word has gotten out about that one that had Dr. Anita Everett and Dr. Belina Shaw. The second most viewed was when 988 launched and it went live, and Dr. Miriam Delphin-Rittman, who's the Assistant Secretary for Substance Use and Mental Health and the administrator of SAMHSA, did that one. So we're just delighted for the popularity of these and getting the word out. And next slide. And this is very exciting. We're going to go to latest crisis news. The White House announces crisis hotline for LGBTQ+ youth. And we're going to play a clip on this.
I know that these political attacks can really take toll on people's mental health. So I want to say directly to LGBTQI+ kids, you are loved just as you are, just the way you are. And if you're feeling overwhelmed, you call 988, the National Crisis Hotline, and dial the number 3 to talk to a counselor who has been specifically trained to support LGBTQI+ kids.
Thank you so much. That is so important in this day and age. And last week there was the LGBTQ session, and it was very popular, very well received, and we so appreciate the presenters from that crisis jam. And next slide. And this is 988 Crisis Line helps Dee Dee Hirsch counselors save lives, and just wanted you to be aware of that news and the articles in the chat there. Next slide. And this is the next headline. LA promised mental health crisis response without cops. And why isn't it happening? So just be aware that that's also in the chat if you want to take a look at that article. Next slide, please. And I'm just wondering if Audrey Wheeler is on.
Yep,
Audrey,
right here, Megan.
Wonderful. Why don't you tell about this wonderful things that you're seeing? Go for it.
Thanks. I'm Audrey Wheeler. I'm from Guide Consulting Services, and I just wanted to quickly share that we've been seeing some 988 advertising happening around the DC metro area. These photos are from Union Station, Metro Center, and Gallery Place, so some of our top train stations in the city. And it's just been an initiative going on from the DC metro system to try to increase awareness of crisis services and crisis prevention. So we're super excited to see this happening around the capital city.
That is really exciting. And my daughter has actually seen 988 posters in her school, and she knows what it is, and it is so exciting for her to see that. If you have connections with school, we encourage you to have them get 988 up on their walls. Next slide. Thank you, Audrey. Great. And somebody just said they're seeing 988 across New York City as well. It's great. And then the next, let's see, coming July 12th, 988 turns 1, and Monica Johnson from SAMHSA will be the featured presentation for that session. So can't believe it's already turning 1. That is so exciting. Can't wait to see you, Monica. Thank you. Next slide, please. And wanted to highlight the SAMHSA store. There are stickers and safety plan pads, wallet cards, magnets, posters, lots of products, as well as there are 6 Spanish options, and you can receive up to 326 materials for free. So there's the link to be able to order those materials, and we hope you get them and enjoy them. Next slide, please. And I had said this before the jam started, but get your t-shirt, get your hat, get your logos. As you can see, there are English and Spanish versions. There's long sleeve, short sleeve, quotes, just really special shirts. I'm wearing mine today. And if you're in the trivia hot seat and volunteer for that, you get a free t-shirt. So, so go for it. It's a great way to get the word out, and it's fun, and they're beautiful. Next slide, please. Great, really excited to introduce Nick Margiotta, who wrote the business case. He did the research and wrote the business case for the Crisis Now model. And so it says in 2016, Mercy Maricopa reported 22,000 individuals in the metropolitan Phoenix area were transferred by law enforcement directly to crisis receiving facilities or community-based mobile crisis. And so law enforcement bypasses the emergency room and proceeds directly to crisis with a 5 to 7 minute turnaround police drop off. There's no call, no referral, no rejection. It's just simple. So we're going to turn it to Nick for the hot seat today. Nick, are you on?
Nick is having some technical difficulties. I'm not sure if he can join.
All right. Should we make this an audience one?
Yep.
Okay, great. So this is going to be like everybody's in it together, right? All right. In 2017, Nashville initiated a business case analysis of Crisis Now, studying the impact of Maricopa County's crisis continuum and specific practices in Greater Phoenix, Arizona. Which of the following was not one of the annual outcomes? Not one of the annual outcomes, okay? That 37 FTE police focused on public safety, or reduction of 5 years unnecessary jail time. And Nick, I am going to turn this over to you because I see you. Can you hear us?
Yeah, yep, sorry, as usual, there's all kinds of tech issues. So I'm here now, so I
course.
missed whatever you did up to now. So, but I'm here now.
All right. Well, we touted your excellent work on doing the business case for Crisis Now and went into some of those statistics. But I'm going to start this. In 2017, Nashville initiated a business case analysis of Crisis Now, studying the impact of Maricopa County's crisis continuum and specific practices in Greater Phoenix, Arizona. Nick, which of the following was not one of the annual outcomes? A, 37 FTE police focused on public safety. B, reduction of 5 years unnecessary jail time. That's a cumulative total. I'll note that. C, behavioral health spending reduced $260 million. Or D, reduction of 45 years of psych boarding. Nick, what do you think was not one of those?
Well, I believe I know the answer, but it seems like a lot more fun to poll the audience first.
All right, then let's poll the audience. everybody use the poll, not the chat. And all right, submit your answer. And so you want to see the poll, Nick? The
Sure.
response? All right, great. Oh my gosh,
Mhm.
that's about as split as I've never seen it that split. I'm sure it has been, but so what do you think?
Mhm. Well, I believe, and I'm just trying to see if there's anybody that I know on the call that I want to embarrass and get their advice, but a lot of people. I'm going to go with B. I don't think we were focusing on the jail time of that. I think we were focusing more on those other factors. So I'm going to go with B.
B as in boy? Great.
B as in Bravo, yes.
All right, great. So it looks like that is the answer. So which of the following was not one of the annual outcomes? Reduction of 5 years unnecessary jail time. So the team believed these crisis services had a substantial impact reducing unnecessary jail incarceration, but the authors could not obtain the data or modeling required for a thoughtful analysis or specific impact. So that means there were 37 FTE police focused on public safety. Behavioral health spending was reduced $260 million, and there was a reduction of 45 years of psych boarding. If we can go to the next slide. And great work, Nick. You're seen in the chat. Great job, Nick. And woo. And so here are some
and let
of
David
the,
know I'll be over his house to pick up my $1 million. I'll be there in a couple hours.
I hope you share it. That's all I can say. And so these are some of the summary of how the crisis now model has made a difference. And there's an improved crisis clinical fit to need by 6 times, saved hospital EDs $37 million in avoided costs and losses. It's reduced total psychiatric boarding by 45 years. It saved an equivalent of 37 FTE police officers, and it's reduced potential state inpatient spending by $260 million. Excellent work to make all this happen. Let's go to the next slide. Thank you, Nick. Okay, and this is a quote from Dr. Richard McKeon. He's the 2023 recipient of the AAS Lewis Dublin Award for Lifetime Achievement and Outstanding Services and Contributions to the field of suicide prevention. Well-deserved, Dr. McKeon. Absolutely awesome work you've done. His quote is, "Zero suicide proposes that all suicides are preventable, even up until the last moment." In 2018, Dr. Richard McKeon clarified this view. Quote, "This doesn't mean a family has the power to stop it, nor that even a clinician who has a duty to care has the power to stop it under all circumstances. We mean that no suicide is fated. None are predestined. Until the person actually takes a final lethal act, there is still hope." Beautiful quote. Thank you, Dr. McKeon. That's a beautiful balance between what we can do. All right, moving to the next slide, please. Delighted to introduce Dr. Debra Pinals. She is the senior medical advisor as well as forensic advisor and chief editor for NASHBIT. She has edited and been involved with our technical assistance papers for several years. And I'm going to turn it over to you, Dr. Pinals. She just does excellent work on behavioral health and law enforcement models to keep improving responses. I'm going to turn it over to you, Dr. Pinals. Thank you.
Great, thank you. And thanks everybody on the Crisis Jam. What a great show this has been already today. So thanks for allowing me to join. I often ask myself, wow, I went to medical school. How did I end up thinking a lot about law enforcement and behavioral health? And, I've had the opportunity to do police training, develop curricula, help run programs for co-responders and CIT and all sorts of other things in my career and all sorts of crisis services and work in the emergency department. And also work as an expert witness in my forensic role, looking at some unfortunate outcomes in police encounters with people with serious mental illness. So we have resources for you that I've cited here, the law enforcement and crisis services, past lessons for new partnerships, and then the lending hands piece that we just did last year. Really hope people take a look at those, and we can go to the next slide. Because what I want to talk about is, and this is just a little bit about me, Megan already introduced me. I don't have any conflicts for this presentation, but we can go to the next slide. You know, there's many things to say in this space of the role of law enforcement in the behavioral health continuum. And really, we need to think about it. I always say, you know, that there's many partners that have to come together for things to go right. I loved Richard McKeon's quote. There are many ways that things can go wrong, but there are also ways that stars can align to go right. And the more we help make those stars align, the better. Not always possible, but can be possible as we think about it. So law enforcement, emergency medical services, and behavioral health specialists will increasingly need to partner and coordinate. We have a paper coming out about 988 and 911 interoperability this year. And the critical infrastructure of crisis services are going to require more and more clarity about how to best execute responses. It's one thing to sort of blame one side or blame the other, but as we look at partnerships, we have to look at shared risk and responsibilities for our communities. And mental health and law enforcement have a long and complex history of collaboration to help individuals get into treatment and to keep communities safe, with important lessons for how we look at the future. So we can go to the next slide. We also have to think about very carefully the intersectionality of mental illness and race. We know more people with serious mental illness who are Black are shot by police than other populations. And there is this intersectionality that we really have to pay attention to. We also have to pay attention to intergenerational trauma cycle and cycles of violence and poverty that play a role in how crises emerge, community policing strategies, and the like. And so thinking about those cultural issues is going to be really important as we think about the partnerships and trying to get equitable and just responses for people and help people get to help when they need it. The role of mental health and behavioral health crisis response for the future also has to have an equity lens, just like we're asking the law enforcement responses to have an equity lens. And we saw some of this in the recent DOJ report showing the Louisville Police Department with DOJ finding discriminatory practices both based on race and based on issues related to the Americans with Disabilities Act for people who have mental health and other kinds of disabilities in terms of getting best practices that don't currently exist, and really many communities are trying to establish in the best way possible. Next slide. So I like to think about, you know, this very much how 911 established more and more. We know how to do CPR. We have AEDs in airports. We have to think about how to deliver out of hospital care or pre-hospital care, now pre-crisis stabilization units, and think about what is that going to look like for people in behavioral health crisis. And traditionally, we see in the literature that when we look at programs and models, there's so many different flavors and sizes right now that I really still like to bucket them in this way. Is the program model based in a police department? Is it a police-based specialized police response? In other words, are police getting specially trained or having a special unit that is designed to respond? Is it a police-based specialized mental health co-response where you have within that police department a behavioral health clinician who's hired to be in the squad car, going out to the scene, developing practices? There's also the mental health-based mental health response, which means that the behavioral health system has staff, or the local provider community has staff that they utilize that can go out to do that response and sometimes meet the law enforcement officer on the scene or meet EMS on the scene. Or there's blended and innovative models, and more of these are becoming multidisciplinary in nature with EMS and nursing and healthcare workers and all sorts of peers and other support professionals that can come to the scene and do some kind of blended approach. A lot of this development depends on where dollars are flowing, who's developing the protocols, but regardless of from whom the dollars are flowing, the models really need to be done with the thought of the entire system structure to leverage the partnerships. Next slide. We can go to the next slide. Yep. And so what does the research tell us? Well, the research is actually still sorely needed. I mean, we have Amy Watson comes to the Crisis Jam occasionally, and she's done some amazing work, but people say, you know, and we all love CIT. There is evidence that it helps improve officer level outcomes and likely call level dispositions in terms of what happens once the call you know, is handled by a CIT trained officer, but there still remains data challenges looking at real conclusions about arrest rates, whether criminal complaints are still filed, whether, you know, use of force and injury outcomes related to just having CIT training only. So we need more studies. I know there's some really interesting head-to-head comparisons that are being done, and I'm really excited to see where those lead. Another recent study that came out looked at 62 different published studies with finding that the methodology of the studies is not great from a scientific perspective, and sometimes show bias in those response in terms of the findings of the studies. One thing that does seem clear is that those youth models with crisis resolution in homes are showing positive outcomes. And then we need to really drill down on what the evidence is for basic co-responder, CIT, and even non-police models. So we're really building this bridge while we're walking on it. And I think we need to be humble about that. People get very excited about their programs and their data. We really need to build a database that really can help inform the future as we go forward, just like we have, again, with CPR and other types of out-of-hospital care. Next slide. So we see emerging models. So embedding a social worker, for example, within law enforcement, bringing behavioral health expertise to EMS responders and using protocols. There's some new emerging protocols for EMS for themselves to do different types of behavioral health responding, multidisciplinary team responses, engaging community and the lay public to respond to phones and chats, what that's going to look like and how do we train them, thinking about bifurcation or merging of crisis response within children's systems, meaning in some communities, such as rural communities or where there's staffing issues, we may not have a separate children's crisis response team. It may be merged with an adult crisis response team, but yet because the models in you know, a safe place to be and the SAMHSA guidelines require specific, not just adding children's services on as adult services, but really having a different framework, thinking about families and crisis stabilization, really important that where those staff are going to be doing responding to all age groups, need to make sure that the models that we're building have fidelity to what we are learning will work. And then also looking at unique population needs, like people with intellectual and developmental disabilities that have to be thought about in this framework. And that's just one population. Many others we heard earlier, you know, LGBTQI and others that really need to be thought about in terms of how we address different needs. Next slide. So we wrote about, and I've written a lot about this and thought a lot about this, you know, what is a high-risk situation when we look at emerging models? First of all, many communities have, we're really trying to reduce the reliance upon law enforcement whenever possible. That's really a goal so that law enforcement can do the things that we really need them to do to help keep communities safe and we can get people the best behavioral health response. But that then starts to beg the question of where do you draw the line? When is law enforcement needed? So I see lots of police reports, you know, in my forensic work, people coming in through forensic processes with, you know, assault and battery with a dangerous weapon. And I've seen that dangerous weapon, everything from a sandwich to a perfume bottle to a knife or a gun. We know that injuries from knife wounds are incredibly significant for law enforcement. That's a major source of injury. We certainly don't want to put behavioral health trained behavioral health specialists in a dangerous position, nor do we want law enforcement to be in a dangerous position. So how do we think about what's going to get the most safety? For example, if a behavioral health specialist is able to de-escalate a certain person with an officer clearing a scene, how do you develop protocols so that nobody gets hurt? So that's something really we need to think about. Hardline rules about, whether when there's a weapon present really should look at what do we mean by that. And these are really hard things to delineate. Suicide by cop is another really interesting thing. That's an old expression. Some people call it victim precipitated homicide or law enforcement assisted suicide. All of those are very complex terms themselves. Many of these situations are these are volatile situations. De-escalation in many ways can work, but we have to understand what is this phenomenon and how do people get to it, to look upstream at best approaches that can be really very, very unsettling for everybody involved and very traumatic, let alone potentially lethal. And then there's barricade and hostage situations. I've certainly been involved in some of those. I'm going to talk about that. And can alternative strategies be effective for communication and situation resolution? So what are the on-the-ground protocols that are developed across the systems that I really think is where we need to take this next phase? Triaging to different responders or multiple responders, just like we think about when is it a panic attack versus a heart attack? When is it just a straight robbery versus somebody who's got a psychotic illness that we need to treat? A suicide crisis with a firearm needs to be handled, obviously, in a particularly sensitive way. And when is there alcohol and substance use involved where the person might have a knife? How do we think about triaging those calls? Joint training is definitely, I think, going to be one of the keys that we need to understand so that the left hand, right hand, and middle hand are all kind of knowing what's going on. And then looking at data, and doing after action reviews, just like we do in all systems for quality improvement. Look at what did we do right? What could we do better? How do we keep driving to least restrictive responses for system improvement, always with that equity lens. Next slide. I'm really excited that on this crisis jam, we have some of my colleagues here. And I just want to say that I was brought into this 36-hour standoff in Washtenaw County, which is the county that serves the University of Michigan in Greater Ann Arbor. We have the sheriff with us today and the director of our crisis services for our community mental health. During COVID, I was called to this scene. The community mental health was already supporting the local SWAT team. This was not your usual day. This scene, I'm happy to say everybody came out alive, but there was a barricaded situation, there was a family situation, there was a lot of risk in this, and the remarkable strategies that were used were coordination, patience, and trying to use best practices to drill down to help get relief for this very complicated situation that did involve weapons, but did involve collaboration. Next slide. So what are some lessons learned that we can use? Trauma-informed practices, looking at the trauma of the workforce. That experience alone was quite remarkable, but there are many experiences that people are dealing with daily in the crisis space, and we have to make sure we take care of the workers. Thinking about partnerships that are at the ready and on call and ready to go, not, where relationships are solid. So we don't get to the scene and don't know what each other's roles are or even who each other are. And then that engagement and bringing in peer support, both peers for the people we're responding to, but peers for workers, crisis peers, police peers, EMS peers, really helping each other do better and inform our practices. Next slide. So it's really about interoperability, coordination, and then thinking about liability, which is where I have to take a moment to talk about, when we think about liability, there's lawsuits, malpractice. police get sued, providers get sued. We don't want lawsuits. We don't want bad outcomes, but we really, there are duties that attach when we take on the role of serving people, and we have to follow a standard of care, which means following the care that a reasonably prudent practitioner of similar education and experience would have executed. And that requires us to know what the standard of care is and to develop those standards and understand who's supervising us, what are supervisory authorities, how do we know what our roles and responsibilities are? And then, qualified immunity that are afforded in some situations, such as a government actor who is protected from personal liability if they're acting within their standards and protocols, but not necessarily if they're acting outside of them, which is why this is really important, serious kind of heady stuff, but really important as we learn lessons and as we build out those better practices. Next slide. So we made some recommendations in some of the prior papers. I want to reiterate those, looking into the future in the post-COVID crisis space that we're building out, continuing to drive the efforts to leverage partnerships, training and cross-training, trauma-informed. Next slide. Enhancing roles of peers of all types, training and policies, cross-training, building in stakeholders to have input into what's happening in their community with focus on diversity and equity, and using empirical evidence as we go to continue to build those best practices. Next slide. And with that, I'm going to stop and turn this to our responders. Thanks, Megan.
Great. Thank you so much, Dr. Pinals. And if we have Lisa Gentz, who is with the Washtenaw Washtenaw County Community Mental Health, and she is the program administrator for that. And Sheriff Jerry Clayton, also with Washtenaw County and Michigan's top law enforcement official. So very delighted to have you both. Thank you so much for being here. Lisa, if you could just give your initial thoughts on Dr. Pinals' presentation.
Yes, hello. Thank you so much for having me here today. I cannot advocate enough for the importance of partnerships and building partnerships with your first responders. We have seen phenomenal outcomes as a result of these partnerships that go much further than just connecting with each other after encountering somebody in the community. They really involve co-training, job sharing, data sharing, et cetera, so that we can really ensure that the right response is available in our community and that we have the trust necessary to be able to really sort through these very complex situations that are occurring in our communities. So again, I can provide additional detail, but I would also want to give the sheriff an opportunity to respond as well regarding the presentation. But I cannot advocate enough for ensuring that this co-response element is available, but it involves building trust and having a whole array of responses available when necessary.
Yeah, good morning. Thanks for having me. If I have a little background noise, and forgive the background, I'm actually in Chicago getting ready to join a panel to talk about some of these same things with the City Club. Again, I think Dr. Pinals hit everything right on target. Obviously she's a rock star nationally. We love her in Washtenaw County, and she's helped us establish some of the architecture that we have. But let me start by saying, I think one of the slides she put up is when she asked, what's the most appropriate model? Which one of these is the most appropriate model? My response is they all are. And in Washtenaw County, we think about this continuum of community responders. So there's a role for a variety of different responders depending on what situation we're trying to manage. And we're trying to look at this through this lens of risk and need. People talk about, well, we can just send a clinician or we can just send a police officer. Those of us that have responded to emergencies, whether it's in a police space or a clinical space, know that very rarely are these situations clear, cut, and dry, that there's some mixture of risk and some mixture of need. Now, we've defined risk as the level of dangerousness that person poses to themselves and others, and need is the physiological or psychological requirement for well-being. So very rarely is it clear. And because it's not clear, we should invest from a community perspective to support that entire continuum, whether it's a police-only response because it's high risk and minimal need, or it's clinician response because it's high need, minimal risk, or it's a co-response like we're piloting in Washington County because it's a mixture of both. You have to have those different components in place, or maybe it's just a human services response because that person has a challenge around housing insecurity or food insecurity or some kind of physical health issue. The community has to invest in all of those aspects for a 24/7 response that positions us to provide that person with the best responder to fit the need. Now, I'll end with this piece. I'm always concerned when we get into this rhetoric that we have to do this absent any one of these partners. Now the rhetoric is more, we have to do it absent the police. But there's been conversations about absent the other partners. If we're gonna create well and safe communities, we must invest in every one of those aspects and support those community responders, co-training, co-education, so we can receive the kind of outcomes that we want for the folks that we're trying to serve.
And Sheriff, to highlight, we just had some research done from the Center for Behavioral Health and Justice here at Wayne State that showed some phenomenal outcomes based on, all of the attention that we've really focused in Washtenaw County on this right response at the right time. And in comparison, the officers of the Sheriff's Office were connecting individuals to treatment 30% of the time that they were interacting with individuals in the community, as compared to 4% for other law enforcement organizations. As well as our mobile crisis team really goes beyond just being out in the community for the initial crisis response. We focus a lot of our work in stabilizing that crisis, so much so that we provide on average about 14 contacts in the 10 days post initial crisis to ensure that individuals are getting connected to the right care to meet their needs, and then staying engaged so that they stay connected to those services.
Yeah, I know we have to, I'm sorry, I know we have to move on. I'll just add this last piece. This doesn't happen by accident. That all the partners have to be really intentional about the outcomes that we want to see. So we start with this mission or outcome, drive strategies, drive structure. So our conversations are really around whatever strategies we put in place, whatever investment we make, what are the outcomes that we want? Dr. Pinals talked a lot about equity. We talk a lot about the appropriate responder, providing the appropriate trauma-informed, do no harm services to folks. If we're really, really good, we're putting in programs where we're meeting people upstream before they get into crisis. So I think one of the takeaways for us from a community is let's be sure of where we want to go. And then we can start to plot the plan, the path, and get the right kind of community investment to get there.
Thank you both so much. I feel like we could pull out 5 different quotes from you that we can use for next week. Right response at the right time, just the equity lens, the building of the trust, the where do we want to go, and what the outcomes that we want. And design it around that. And it's right in the moment, isn't it? Like you have to decide. You're not just saying cookie cutter, we're going to do it like this and expect that to work. It's got to be what is going on, what you're talking, Jerry Clayton, you're talking about the different risk and then what the need is. Lots of things to consider. This has been a very thoughtful presentation and thoughtful comments. We really appreciate you being on and helping us think about what we need to be thinking about. So thank you so much. Okay, we're going to move to James Wright from SAMHSA. James.
All right. Hello, everyone. Thanks for having us this morning or this afternoon, depending where you are, and hopefully you can hear me well. A couple quick updates from SAMHSA. We are really excited to be able to announce that as part of focusing on increasing access for underserved, high-risk, and marginalized communities, I'm excited that we have worked towards the next steps of formalizing access through 988 for our LGBTQI youth and Spanish-speaking populations. So for those that have heard or not, access during the year for LGBTQ youth was activated for phone, chat, and text. Last week at AAS, Vibrant and SAMHSA highlighted that roughly 6% of all of our calls that came through the phone for 988 requested our Press 3 LGBTQ access services, and 11% of all of our chats and our texts. Also through the year, that was roughly about 200% of our original estimates for this population accessing these critical services. And so I was super excited to see yesterday. I want to thank Vibrant Emotional Health, the network administrator, for moving this next step forward. RFPs that have been released for building permanent structures for LGBTQ youth chat, text, and phone services. And then also announcing for the first time RFPs for the activation of Spanish chat and text. We expect all of these services to be active permanently this summer. So please be on the lookout for that. We know we are also helping partner and work through other areas that need further 988 expansion and support, including areas such as individuals that are deaf and hard of hearing, IDD, refugee and migrant populations, and just trying to look at who we're able to serve and who we're not able to serve, who are accessing care currently. So with that announcement, I also want to announce 2 new members of the 988 team at SAMHSA. And speaking of our equity work in enhancing access to care, I want to go ahead and announce Dr. Laura House, who is our new Equity and Engagement Officer. So Laura, if you can come off and just wave, there's Laura.
Hi, everyone.
Welcome to the 988 team. And then also Aisha King, who is a special assistant in the crisis operations team as well. I believe you're on.
Yes, I'm on. Hi, everyone.
Oh, perfect. So the 988 team at SAMHSA definitely is growing. So thank you for allowing us to give those updates. I do want to end with just a call out to Richard as well. I saw the earlier slide, and I've had an honor to work with Richard for the last 12 years. And there are definitely people that are passionate about crisis and suicide work. And then there are those that truly dedicate their lives. And anyone that knows Richard knows that this is beyond a passion. This is his life's work. And I believe that we are all better for it in this field than those that reach out for care. And one of the things that he will continue working on, and I'm about to pass it to Megan on, is the new call for the revamped National Strategy for Suicide Prevention. So if you were unaware that the White House and the Domestic Policy Council called for not only a revision of the National Strategy for Suicide Prevention, but also for the first time a true action plan on that prevention plan itself, which was not accompanied by the 2012. And so the target release date for that is January of 2024. And I know 3 of the leads from the federal government will be Richard McKeon, Brandon Johnson from the Suicide Prevention Branch, and Deb Stone from the CDC. So a little bit more about that. I'll turn it over to Megan, and thanks. Happy to answer any questions from the SAMHSA side. Megan?
James, thanks so much. It just really warms my heart. You just put into words so perfectly about Richard McKeon and his life's work. That is just so true. When you're around Richard, you just feel that. It's fantastic. And Dr. McKeon is going to be presenting on May 31st, actually on the national strategy. So really thrilled that he'll be doing that. And if we can go to the next slide, please, talk about just piggybacking on what James was saying. SAMHSA and the Action Alliance and the Suicide Prevention Resource Center are collecting stakeholder input to help inform the revision of the National Strategy for Suicide Prevention. And an online needs assessment has been created to help them solicit feedback And they are inviting this Crisis Jam community. If you're on this call and you have colleagues as well, please share the link there. We'll put it in the chat as well. And we invite you to participate in that needs assessment. Thank you. And next slide, please. I'm now going to turn it over to Tom Betlach to talk
Thanks,
about
Megan.
Medicaid front and center. Yep.
Yeah, we've had the opportunity to highlight several different things in this part of our calls on a monthly basis. We've talked about how Arizona has consolidated call centers into a single statewide call center by leveraging Medicaid. We heard from Idaho in terms of they're leveraging a managed care procurement. We've heard from CMS in terms of their efforts to advance technical support to states. And on a previous call, we also highlighted some work that's out there that Virginia and Arizona have put together to help states look at resources that are available. And this week, we're going to hear from Jason McGill from the Washington Healthcare Authority to hear in 4 minutes or less, Jason, what is up in Washington and how is Medicaid supporting crisis delivery? So Jason, if you can take it away.
Hi, Tom. Thank you all. What a great discussion this morning, and really appreciate our team who's on the call and attend these on a regular basis. We really get a lot out of these conversations with other states. So a little bit about Washington. What we have done most recently is sort of integrated behavioral health care with our Medicaid program. In addition to that organizational structure, which is important from a financing point of view, and then a leadership structure from a governor on down in terms of not only behavioral health writ large, but certainly crisis, certainly suicide prevention, and really developing plans, strategic plans, and work across partners to develop systems such as 988. So I want to just emphasize, it takes that sort of organizational structure, it takes that sort of leadership structure from the legislature and the governor. And so we're, I think, very fortunate to have that. We help on the Medicaid side, particularly, and just a couple of points I'd make there. Financing, and thank you CMS to help clarify mobile crisis financing for Medicaid, but we're not done. So we want to continue looking. Tom's been a great leader in Arizona to help us in terms of work that we know we can get funded through Medicaid, but how do you get those systems integrated? How do you get that funding working? And what more can we do? So, we're not stopping at mobile crisis and figuring out ways to fund. We've got a system with managed care plans and administrative service organizations that we call our behavioral health administrative service organizations to fund and to cover that non-Medicaid service, and working together across the state on that. In addition to county electeds and local behavioral health leaders, so we know what's happening on the ground and assess those needs. And as you know, workforce is an incredible challenge across the board. So what can we do to really improve workforce, improve parity, improve regulations and accountability for private coverage? So our legislature, for example, just funded some major rate increases for our behavioral health providers and our crisis service providers. So that, I think, is absolutely critical. We have commercial coverage coming online for next day coverage using our 988 and crisis lines coming online. And of course, easier said than done, especially with workforce crises and systems that are not integrated. So we need to get those referral systems planned out well, need to get those 988 referrals into actual services and handoffs done very well. So incredible work there. And I maybe just a final point, Tom, just on continuing sort of working with Medicaid, assessing what we can get Medicaid funding for and ensure we can maximize coverage to the Medicaid program in as integrative a fashion. Our legislature is also directing us to look at those services that Medicaid relies on that are more 24/7 crisis service, like a firehouse model design. How can we get that better funded through Medicaid, maybe using tools like directed payments through managed care. So I'll end there, Tom. Thank you.
That's great, Jason. You guys are focused on all the right things. I love it. Thanks for the update from Washington. If you can just take 1 minute, there were a couple of things in the chat. I think you really touched on a note with the commercial. So maybe if you can just go into the chat, Jason, and highlight what legislation or the policy decisions you all have done around that. But Megan, back to you. Thanks so much,
Great.
Jason.
Fantastic. Thank you, Tom and Jason. Just as Tom said, you hit all the right things. Where NASHBID is thinking about all of those points as well. So thank you. We are now going to go to the crisis talk. I'm going to turn it over to Christy Malik, who is NASHBID suicide prevention lead. And I'll turn it to you, Christy. Thanks for being on.
Thanks, Megan. So my colleague Bailey Ezekiel and I had the pleasure of interviewing Dr. Montserrat Allende Santos and about Puerto Rico's 988 system. So great. Thank you, Dr. Allende Santos, for joining us. She is the director of Puerto Rico's 988 crisis line called Linea Paz. Dr. Allende Santos, in the interview, we were really struck by how known and trusted Linea Paz is in Puerto Rico. How have you been able to build that trust through Linea Paz in the transition to 988?
Sí, buenas tardes a todos. Cuando trabajamos hablamos de la línea Paz es primera ayuda psicosocial y llevamos 22 años de servicio en todo Puerto Rico, 24 horas los 7 días de la semana.
Okay, so yes, good afternoon all. We're talking about the PASS hotline. We're talking about first psychosocial help. That's what it means. We have been working for 22 years of service, 24/7 days a week.
Es un servicio que brindamos no solamente a través del teléfono, sino que también tenemos un equipo de alcance comunitario, el cual está brindando los primeros auxilios psicológicos casa por casa. Adicionalmente, tenemos el equipo móvil de intervención en crisis, más damos adiestramiento. Son unos servicios que ofrecemos a tiempo real. Nos movilizamos en el momento de la crisis, de la emergencia y el desastre, y en medio de la necesidad podemos cubrir las necesidades básicas a nivel emocional, y eso da confiabilidad a la población.
So this is a huge interdisciplinary team which covers community outreach, and not also community outreach, but also we have a mobile crisis team that moves on real time to help and assist on the crisis, to deliver different emotional strategies, and that builds trust among the communities.
Es un servicio basado en todo lo que es que el participante inicie su proceso de recuperación con sensibilidad, con respeto, con dignidad a todas las poblaciones.
This is a service based on everything that has to do for that participant to receive or to start their process to get well and receive well-being.
Thanks. Can you speak about the 988 Spanish sub-network and Linea Paz role in providing services for Spanish speakers who call 988?
A través de la línea del 988 en español, estamos recibiendo todas las llamadas de la población de habla hispana de diferentes países. Es enriquecedor porque tenemos que ser competentes y humildes culturalmente ante la necesidad, la desesperación que están viviendo toda esa población.
So through the 988 and the Spanish sub-network, we are currently receiving calls from Spanish talkers from all of the nation. It's a very special population that you have to work with cultural humbleness to deliver the needs of that population.
Es una población la cual tiene muchas necesidades, muchos miedos, muchas inseguridades, y el poder brindarle ese apoyo, esa estabilidad emocional, canalizar y coordinar los servicios y darle el seguimiento adecuado, fortalece para que inicien su proceso de recuperación emocional.
So it's a very sensitive population because they have a lot of needs and also insecurities and fears. So being able to assist them through all the whole process, canalizing and delivering follow-up is special to them to help them reach their well-being.
Es un compromiso en brindarle la seguridad. Y entiendo que el éxito de nosotros como programa ha sido la integración y el apoyo de SAMHSA con Línea Paz en el fortalecimiento. Nosotros tenemos al señor James Bryce como GPO, en nuestro guía, en nuestro asesor y nos fortalece para que sea un servicio de excelencia.
It's a very huge compromise, which delivers trust, because when we deliver the services, we are doing it integrated with the assistance and the integration of SAMHSA and our GPO, Mr. James Wright, who's always been there to assist us with everything that we need.
Thank you.
Thank you so much, Dr. Allende Santos. It was such a pleasure interviewing you and just to hear about your passion for 988 in Puerto Rico. So Megan, I'll turn it back over to you.
Thank you so much. What excellent work. And we encourage you to read the article. It's just some great comments there. Thank you very, very much for the work you're doing in Puerto Rico. Next slide, please. And great, I want to bring on Caitlin Davidson from Vibrant Emotional Health and Stephanie Pasternak from NAMI.
Thanks so much, Megan. Good to see everyone this week. It's been such a great crisis jam so far. We do have updates on 3 different pieces of legislation that have moved through the process in various states this week. No updates to the map, but one thing we've been tracking is the budget bill in Minnesota, which is SF 2995. And this bill passed through the Senate. It's their Health and Human Services Omnibus bill last week, and included 988 language, as well as a telecom fee of up to 25 cents. We also saw last week that the House Ways and Means Committee did amend the bill to take out the telecom fee and instead fund 988 through an appropriation. We're hearing from folks on the ground that they are working through this in a conference committee to see if any language regarding the telecom fee will be added back in before the full House vote. So we are going to watch closely, and we'll keep you updated on the progress of that. And with that, I'll turn it over to Stephanie to talk about a couple other bills.
Thanks, Caitlin. Yeah, I have a couple states, and actually a late breaking update for a state that's not highlighted on the map yet, but I will get there. Wanted to start over in Washington State. So this has a pair of bills related to 988 that are headed to the governor's desk. And these are different from the bills that we just heard Jason reference that Washington State passed earlier in 2021. The first one is House Bill 5120. This establishes 23-hour crisis relief centers in the state. There is also House Bill 1134. This really does a number of things. I'm just going to highlight a few things. It creates an endorsement for mobile crisis teams that meet certain staffing and training standards, and then sets up a performance payment program to support them. Also sets the state up with a statewide marketing and social media campaign, and establishes liability protections that will support the transfer of calls between 911 and 988. The other state I wanted to take a moment to highlight is Florida, and really the work of the Florida Mental Health Advocacy Coalition, who are responsible for the recently passed Senate Bill 914. And this requires the State Commission on Mental Health and Substance Use to assess their current capacity of their 988 lifeline and crisis services more broadly, and report on that to the legislature, and also about possible funding sources for 988's long-term future. We don't track study bills on the map. We do have it in our by the numbers section, but I just wanted to take a moment to pause there. I know we haven't talked about a study bill in some time, but just a reminder, these bills can be a really great way to gather data on crisis care in your state. The reports can generate a roadmap for future actions, and also just generate conversation and educational opportunities on 988. And then finally, a late update that is so late, our map is not updated yet, but there is a new bill in Alabama, House Bill 389, introduced by Republican House member Rex Reynolds. And this also includes a 988 fee in there, and I will include a link to that, but I know we are quickly running out of time, so I will toss it back to Megan.
Caitlin and Stephanie, thank you so much. This is good news and some progress there. So we always appreciate every step of progress. And next slide, please. And great. Is Gabriela Silos on, or Silos?
Solis.
Solis.
It's okay.
So sorry.
No worries.
Okay. Gabriela, can you tell us about this opportunity, please?
Yes, of course. Hi, everyone. My name is Gabriela Solis. I'm a project leader here at the Government Performance Lab. We're a technical assistance and research organization based out of the Harvard Kennedy School, but we just released a call for applications for governments who are interested in receiving pro bono technical assistance on implementing, improving, or expanding their alternative 911 emergency response programs. So if y'all are interested, we just dropped the link in the chat, and I know I only had 1 minute. There's also an informational webinar on our website right now with everything you need to know about applying, who's a good candidate, and all that good stuff. And I'll also drop my email in case people want to reach out to me directly. Thanks, everyone.
Great. Thank you so much, Gabriela. And just some quick pieces. Next week is Dr. Q English on faith-based, as well as the week after that is on behavioral health and aging. I also just want to quickly say that Moving America's Soul episode 9 dropped and was released last week. And that series is going to be highlighted at the National NatCon meeting, which is happening in Los Angeles next week. So very excited about upcoming pieces. So thank you so much, everybody. Have a great, great rest of your week.